Welcome to this video on precision and anatomy in managing the aortic root. We will explore the clinical pathway from radiological assessment to surgical intervention and outcomes. We must balance the rupture or dissection risk against the surgical morbidity risk. Thoracic aortic aneurysms are a leading cause of death, often remaining asymptomatic until catastrophic failure. Precise imaging is vital for life-saving surgical timing. The end-to-end clinical pathway involves 4 key steps: assessing with 3D-gated CT and MRI, diagnosing pathology and genetic thresholds, intervening with Bentall and root enlargement techniques, and evaluating empirical outcomes data. Mapping the aortic root architecture includes identifying the aortic annulus, the sinuses of Valsalva, the sinotubular junction, and the ascending aorta. Accurate aortic measurement relies on 3 tenets: using ECG-gated 3D datasets, achieving perpendicular alignment in measurements, and maintaining standardized reporting of anatomical landmarks and slice numbers. A critical pitfall is motion artifact from cardiac pulsation in ungated CT scans, which can artificially overestimate aortic diameter. This can lead to inappropriate surgical referrals, highlighting the need for accurate measurement, as shown by echocardiography. The aortic annulus is ovoid, not symmetrical. 2D echocardiography provides a single measurement that typically underestimates the true size. 3D double-oblique CT reveals the true ovoid geometry, necessitating measurement of both short and long axis dimensions. In bicuspid aortic valve, altered flow caused by abnormal leaflet fusion results in high-velocity streamlines that persistently impact the aortic wall. This sustained kinetic energy causes targeted eccentric dilation opposite the fused commissure. Marfan syndrome phenotype profiling is linked to a mutation in the FBN1 gene. The primary imaging sign is annulo-aortic ectasia. Secondary signs include lumbosacral dural ectasia, pectus deformities, and mitral valve prolapse. This diagnostic matrix outlines the pathology, genetics, imaging features, and surgical threshold for various aortopathy conditions, including BAV and Marfan syndrome. Radiological accuracy is the sole arbiter of timing for open heart surgery. Surgical thresholds vary by condition and risk, from 40 mm for Loeys-Dietz syndrome to 55 mm for degenerative cases. The Bentall procedure is the surgical gold standard for severe aortic root aneurysms. It involves 3 steps: resection of the native valve and root, implantation of a composite valve tubular graft, and reimplantation of the coronary ostia. A naturally small annulus forces the implantation of an undersized prosthetic valve, leading to prosthesis-patient mismatch. This results in dangerously elevated transvalvular pressure gradients and increased long-term mortality. Root enlargement techniques like Nix and Manoogian forcibly expand the root, allowing for the implantation of a prosthetic valve up to 2 sizes larger. This can be done without increasing operative mortality risk. The Manoogian approach involves median sternotomy, cardiopulmonary bypass, and transverse aortotomy for access. After debridement, the critical step is slicing through the commissure directly into the aortic mitral continuity to forcibly expand the circumference of the annulus. Seating the valve is done using a teardrop-shaped patch of bovine pericardium to widen the landing zone. Pledged sutures secure the upsized prosthetic valve simultaneously to the native annulus and the new patch. The remaining patch is trimmed and incorporated into the continuous closure. The 2024 clinical outcomes study involves a cohort of 39 high-risk patients requiring end-to-end aortic root reconstruction for severe pathologies. It is a retrospective single-center study spanning January 2019 to September 2024. The surgical cohort was predominantly male at 71.8%, with an average age of 43.9 years. Dissection and Marfan syndrome were the primary pathologies, both accounting for 35.9% of cases. Most procedures were urgent or emergent. Operative metrics show a cardiopulmonary bypass time of 196.10 minutes and an aortic cross-clamp time of 169.05 minutes. The re-exploration rate was 5.1%, with 2 patients due to bleeding, demonstrating low complication rates. The early mortality rate was 2.6%. Only 1 patient was lost due to excessive bleeding in a cohort dominated by acute dissections and urgent interventions. This outcome supports that complex root operations can be performed with outstanding safety margins. Thank you for watching this video on the aortic root blueprint.